Hello all, welcome to this class on beta blockers. In the first part of this class, we will talk of classification of beta blockers, their mechanism of action, properties, uses and their interactions. Beta receptors are of three types: beta 1, beta 2 and beta 3. Beta 1 receptors are located in the heart and juxtaglomerular cells in kidney. Beta 2 receptors are located in bronchi, blood vessels, uterus, liver, gastrointestinal tract, urinary tract and eye. Beta 3 receptors are located in adipose tissue and detrusor muscle of bladder. In your previous classes, you have learnt about beta agonists. Today, let us learn about beta blockers or beta antagonists. First, let us see the classification of beta blockers. The first generation non-selective beta adrenergic blockers. They include propranolol, timolol, nadolol, pindolol, sotalol and levobunolol. The second generation beta 1 selective adrenergic blockers. They include atenolol, acebutolol, bisoprolol, esmolol and metoprolol. The third generation beta blockers with additional vasodilatory effect. They include the non-selective class, that is the labetalol and carvedilol. The beta 1 selective include betaxolol, celiprolol and nebivolol. Beta blockers with additional activity. The beta blockers with partial agonistic activity or intrinsic sympathomimetic property. These are pindolol, acebutolol, labetalol, celiprolol and cartiolol. These drugs stimulate beta receptors partially in the absence of catecholamines. Beta blockers with membrane stabilizing activity. They have local anesthetic property. These drugs are propranolol, acebutolol, carvedilol, labetalol, metoprolol and pindolol. Mechanism of action of beta blockers. Beta receptors are coupled to GS proteins which activate adenyl cyclase to form cyclic AMP from ATP. Increased CAMP activates a CAMP dependent protein kinase A that phosphorylates L-type calcium channels which cause increased calcium entry into the cell. Increased calcium entry during action potentials leads to enhanced release of calcium by the sarcoplasmic reticulum in the heart. These actions increase contractility, heart rate, AV nodal conduction, etc. Beta receptor antagonists compete with sympathomimetic neurotransmitters for binding to receptors which inhibits sympathetic stimulation to the heart. Blockage of neurotransmitter binding to beta 1 receptors on cardiac myocytes inhibits activation of adenylate cyclase which in turn inhibits CAMP synthesis leading to reduced protein kinase A activation. This results in less calcium influx to cardiac myocytes through voltage gated L-type calcium channels. Hence, there is decreased sympathetic effect on cardiac cells resulting in antihypertensive effects like reduced heart rate and lowered blood pressure. Mechanism of action of beta blockers. Beta blockers cause suppression of cardiac output. They cause inhibition of renin release. They cause diminution of tonic sympathetic outflow from the vasomotor center in the brain. They cause restoration of defective vascular relaxation and they also cause inhibition of presynaptic beta receptors. Pharmacological properties of beta blockers. Cardiovascular system. In the heart, beta blockers depress all cardiac properties. They decrease the heart rate. They decrease the force of myocardial contractility. They decrease cardiac output. They depress SA node and AV nodal activity. They increase refractory period of AV node. They decrease conduction in atria and AV node. They decrease automaticity of ectopic foci. They decrease cardiac work, thus reduce oxygen requirement of the myocardium. In blood vessels, blockade of beta 2 receptors of blood vessels initially may cause rise in peripheral vascular resistance due to unopposed alpha 1 action. However, continuous administration of these drugs leads to a fall in peripheral vascular resistance in patients with hypertension due to chronic reduction in cardiac output. They also reduce the release of renin from juxtaglomerular apparatus due to blockade of beta 1 receptors and decrease central sympathetic outflow. In respiratory system, blockade of beta 2 receptors in bronchial smooth muscle can produce severe bronchospasm in patients with COPD and asthma. Therefore, beta blockers should be avoided in patients with asthma and COPD. Selective beta 1 blockers such as atenolol, metoprolol can be used. Skeletal muscle. On chronic use, beta blockers may cause skeletal muscle weakness and tiredness due to blockade of beta 2 receptors of the skeletal muscle and blood vessels supplying it. Metabolic effects. Beta blockers inhibit glycogenolysis and delay recovery from hypoglycemia. They also mask the warning signs and symptoms of hypoglycemia. Therefore, beta blockers should be used cautiously in diabetics on hypoglycemic agents. In the eye, beta blockers on topical administration decrease intraocular pressure by reducing secretion of aqueous humor. Here we can see the actions of propranolol on heart, on respiratory system, on vascular smooth muscles and various neurotransmitters. Pharmacokinetics of propranolol. Propranolol is highly lipid soluble and well absorbed from gastrointestinal tract. Bioavailability of propranolol is low as it has high first pass metabolism. It is highly bound to plasma proteins and has a large volume of distribution. It freely crosses the blood brain barrier. The metabolites are excreted in urine. Therapeutic uses of beta blockers. Hypertension. Beta blockers are useful for all grades of hypertension. These drugs are preferred especially in patients with angina, myocardial infarction, or cardiac arrhythmias. The advantages of beta blockers are sodium and water retention is rare, they are cheaper, they have a long duration of action, and they are well tolerated. In angina prophylaxis and myocardial infarction, beta blockers reduce myocardial oxygen demand by decreasing heart rate, myocardial contractility, and arterial pressure. They improve exercise tolerance and reduce frequency of anginal episodes. Cardiac arrhythmias. Beta blockers are mainly used in atrial arrhythmias such as atrial fibrillation, atrial flutter, paroxysmal supraventricular tachycardia, but they are rarely used for ventricular arrhythmias. Congestive cardiac failure. Chronic use of beta blockers such as carvedilol, metoprolol, and bisoprolol has shown to reduce mortality rate in chronic heart failure. They are also used in hypertrophic obstructive cardiomyopathy, in dissecting aortic aneurysm, and in pheochromocytoma. The other uses of beta blockers include for glaucoma. Beta blockers decrease the intraocular pressure by reducing production of aqueous humor. They are useful in the treatment of glaucoma. Timolol, cartiolol, levobunolol, betoxolol, they are used topically in glaucoma. Timolol is the most frequently used beta blocker in glaucoma. Betaxolol is a selective beta 1 blocker, hence systemic adverse effects, mainly cardiovascular and pulmonary, they are rare. Beta blockers are also useful in prophylaxis of migraine, in hyperthyroidism, in essential tremors, in acute anxiety states, and also for alcohol withdrawal. Let us have a glance at the uses of beta blockers once again. They are used in hypertension, angina pectoris, cardiac arrhythmias, myocardial infarction, congestive heart failure, hypertrophic cardiomyopathy, dissecting aortic aneurysm, pheochromocytoma, in essential tremors, in thyroid storm, in anxiety, in migraine, in glaucoma. Drug interactions. Propranolol along with verapamil, they produce additive cardiac depression effects and they may cause congestive cardiac failure, bradyarrhythmias, heart block, or even cardiac arrest. Propranolol along with lignocaine. Propranolol reduces the clearance of lignocaine by decreasing hepatic blood flow. Cholestyramine and cholestyramine along with beta blockers. Cholestyramine and cholestyramine are bile acid binding resins. They bind to beta blockers in the gut and interfere with the absorption of beta blockers. Insulin or sulfonylureas along with beta blockers. Non-selective beta blockers inhibit glycogenolysis and delay recovery from hypoglycemia. Propranolol along with non-steroidal anti-inflammatory drugs. NSAIDs, by inhibiting prostaglandin synthesis, promote sodium and water retention on chronic use. Thus, they decrease antihypertensive effect of beta blockers. Propranolol along with chlorpromazine. Propranolol interferes with the first pass metabolism of chlorpromazine and increases its bioavailability. The remaining part, that is the adverse effects of beta blockers, selective beta 1 blockers, beta blockers with important features, and beta blockers with additional vasodilatory effect, they will be covered in another class, that is part 2. These are the various references I have used for this class. Thank you.